Welcome back to Pediatric. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
Today is part 2 on high-frequency oscillatory ventilation with Dr. Martin Kneyber. Dr. Kneyber is the chief in the Division of Pediatric Critical Care Medicine at the Beatrix Children's Hospital in the Netherlands. There he is a respiratory disease researcher in basic science and clinical medicine. He is the principal investigator for the PROSPECT, or the Prone and Oscillation Pediatric Clinical Trial.
Yes, we are so excited for the PROSPECT results, but we're also excited for this conversation. Dr. Kneyber transitions to the oscillator a lot sooner than Zach and I do at our U.S. centers, and he is such a good clinical master of the technique. We learned so much from talking to him.
Yes, let's get right to the episode.
All right, so I'm going to take things back to our 2-year-old girl who's intubated with evolving ARDS. She is on SIMV with pressure control of 16 over a PEEP of 14. Her rate is 28. Her FiO2 is 80%. How are we selecting those initial settings?
So you have to look on the mean airway pressure on your conventional. And as said, the initial setting would be 8 centimeters water above the mean airway pressure on conventional. So that's your starting mean airway pressure. I'm going to keep the frequency for the last because that's the most complicated thing.
Okay.
So IE ratio 33%. That's default on the Sensormedics. I would keep it in the beginning. Bias flow for this girl, about 20 liters would be sufficient. We titrate the bias flow somewhere between 20 and 40. Rarely go up above 40 because you might get some CO2 entrainment when you go above 40 liters per minute. That's fine. But then the frequency. If you look at the manual of the oscillator, and if you look at how many people have been taught, the way to do it is to use a age or weight dependent frequency, which is complete rubbish. The way how you set your frequency is defined by the so-called corner frequency. And the corner frequency, that's a really difficult mathematical concept developed by John Marini. Corner frequency is the frequency where the pressure cost of ventilation is the lowest, so meaning where the ventilation settings is the least injurious. And that corner frequency is dependent on the compliance and the resistance of the respiratory system. So in a patient with a low compliance, the corner frequency shifts to the right, somewhere between 10 and 15 hertz. So it means that in a patient with ARDS, you need to start in that range. For a patient with a high resistance, corner frequency shifts to the left, is in the lower range, is somewhere between 5 and 7 hertz. So that's why in an asthmatic, I would start at 5 hertz. But in patient with ARDS, we start at 12 hertz. And a patient with a mixed phenotype, we also start at 12 hertz. You could say, okay, let's do somewhere between 10 and 12, that's fine, but at least not defined by age or weight, because that doesn't meet the concept of corner frequency. Corner frequency is about physiology. So we use this high frequency in the 3-month-old, starting of 12 hertz, but also in the 16-year-old. In patients with either a mixed phenotype or diffuse alveolar disease, 12 hertz in every patient. So that's about the frequency. Now the amplitude. So the amplitude is actually not a setting, but the amplitude is actually a parameter. So on the oscillator, you have a very small knob which says power, and it goes from 0 to 100. So in the big number is 0 to 10, and then you have the small number which goes from 0 to 9. And this power is the thing that drives the piston back and forth. And the displacement of the piston is dependent on the compliance and the resistance of the respiratory system. And this displacement is displayed as the delta P on the oscillator. So we don't use the delta P or the amplitude as a setting parameter, but we use it as a monitoring parameter. So in our patients, we start at 12 hertz in all patients, and we target an initial proximal pressure amplitude of 70 to 90 centimeters of water. In small babies of 3 kilograms, in 16-year-olds. And we know that this big pressure amplitude, it isn't seen at alveolar level. It's attenuated like we discussed in the beginning. We don't go above that 90 because theoretically, when you go above, let's say above that 90, 100, 110, you might get upper airway injury. I haven't seen it, but it might theoretically happen because it has been described in animal models. So that's the initial proximal pressure amplitude. So we don't set it by, for example, you have people who, let's say, do 2 times or 3 times the mean airway pressure, or let's do CO2 times 2, whatever. That's rubbish. That has nothing to do with physiology. And when we do our recruitment maneuver and when we titrate our oscillation later on in the patient, we in principle don't touch that power knob. We don't adjust the amplitude. We manage oxygenation by the mean airway pressure and we manage ventilation by titrating the frequency. Going up if the patient is hypocapnic, going down if the patient is hypercapnic. So initial setting, frequency of 10 to 12 hertz, initial proximal pressure amplitude of 70 to 90 centimeters of water, IE ratio 33%, bias flow 20 to 40 liters per minute.
And would never adjust I to E ratio, correct?
No, only, for example, if you have a patient who has really bad lungs and you cannot ventilate and the cuff is already deflated, then it might be necessary to increase the stroke volume a little bit, and that's done by increasing the inspiratory time. And that can be done at max to 50%.
Understand. Something I expected you to say that I'm sure there was a great reason you didn't, is that you didn't mention anything about titrating the power or the amplitude for what you clinically see, chest movement.
The wiggle, yeah.
Tell us more about why you think that's not necessarily helpful.
Well, the wiggle is really fascinating because everybody wants to look at the wiggle. I think of the wiggle as somewhat binary. So it's absent or it's not absent. And I don't really see a strong correlation between the amount of chest wiggle and whether or not it goes up to the umbilicus or whether or not it goes up to the groin and lung aeration or sufficient ventilation. It should be visible, but the way the patient is wiggling is, in my view, doesn't help you in titrating or setting your oscillator settings. So it's really binary. If it's not present, then there's something wrong.
Yeah.
Like ETT blockage or pneumothorax, that kind of stuff. But quantifying the degree of wiggling,
yeah,
I wouldn't go there.
I'd say there's something intrinsically satisfactory about, you get this child transitioned over to the oscillator. The RT is just titrating that power on the knob, and then the nurse, you're looking at the patient. Oh, we have a good wiggle now. We should be good. Please get a blood gas and give me a call. Yeah.
I know. Yeah. We don't use chest radiographs to assess lung aeration and the effect of the recruitment because we know there's no really good data, but there's a little bit limited data from some neonates as well, that there's a very poor correlation between lung aeration as assessed by chest radiograph and actual lung aeration. So after the recruitment, we only do a chest radiograph if we think there is a pneumothorax. But we publish this 60 recruitment maneuvers, 0 pneumothorax in all those patients.
Oh, wow. That's wonderful. And to pay attention to the way that the patient is oxygenating and ventilating does make sense.
Yeah. So, if you do a chest radiograph and you see that the diaphragm is really flattened and it's, let's say, at rib 12, then probably you are in overdistension. But it's magical, it should be 9 or 9.5 or 10. I don't think it adds that much.
Mm-hmm. That's very fair.
Always learn a lot at each of these episodes. And I feel like my endearment that I had for the chest wiggle and then the chest x-ray for titrating my oscillator, I'm learning maybe it's not as valuable as I thought.
Oh yeah. I love an x-ray. I do love an x-ray.
I'm sorry to pulling you out of your comfort zone on this,
but that's amazing.
So I just want to repeat this to make sure that I understand it. The corner frequency has to do with how much of that oscillation is actually transmitted to the lower airways. And so if you've got low compliance alveolar disease, you're using a higher frequencies for sort of a smaller amount transmitted down. And if you've got high resistant airway disease, you're needing a lower frequency, 5 to 7 hertz, to really make sure it's transmitted down.
Correct.
And a hesitancy, I guess, in my practice over the last 2 or 3 years is worried about using the lower hertz because of injurious potential tidal volumes. But I imagine in those patients with high resistance, bronchospasm, maybe there's going to be a significant pressure attenuation. Their alveoli is not going to see those volumes. Is that your rationale?
Yeah, that's correct. We did a bench test where we simulated air resistance. In our lab, we have this single lung flask model, which is a 50-liter bottle, which we fill with water to simulate compliance. And we simulate resistance. Well, we cannot add resistance, but we just prolong the endotracheal tube, which is one of the components of the formula of resistance, of course. And we found that with increasing resistance, the pressure that's seen inside the bottles was so negligent. And even at 6 hertz or at 5 hertz, it's, of course, much stronger attenuation at 10 hertz, but even at 6 or hertz, then there's a really small oscillation at alveolar level. Yeah.
Oh, nice. Sort of the lab version of a plateau pressure and getting dynamic versus static compliance.
Yeah, absolutely. Yeah.
So you've walked us through your stepwise protocol. It truly sounds fantastic. If your patient is persistently hypoxemic on the oscillator, how are you adjusting settings to improve your oxygenation?
If the patient remains hypoxemic, refractory hypoxia, we would do the recruitment maneuvers and see if, for example, if the patient has become more recruitable or not. But let's say still if the FiO2 is 0.8 something and there seems to be no response, that would be for me the moment to turn the patient prone.
Mm.
And I think then the benefit of combining prone and high frequency is that with prone, of course, you get a better distribution of transpulmonary pressure, and with the oscillation is smaller stroke volume. And then if the patient doesn't improve in oxygenation over the next couple of hours, we would probably then go cannulate for ECMO. But I said the last 2 VV ECMOs we did, and we don't do that many runs because we do mainly cardiac or sepsis ECMOs VA. The 2 VVs that we done that are in our database were because of status asthmaticus and massive barotrauma, because they came in with massive barotrauma from another hospital already. Those were the ones who we managed with VV. Yeah. So if refractory hypoxemia and recruitment doesn't work, flip prone, and if then no improvement in several hours, then probably cannulate.
And a follow-up question here, what level of FiO2 do you determine we've got appropriate recruitment? Is it at FiO2 60%, 80%, 40%? Like, what is your target?
Yeah, classically, we've been told, okay, if we come down to 0.6, then we were happy. We have set the bar at 0.5. We really want to go down to 0.5 and even lower if possible. But if we end up at 0.5, then we are pleased for that time point. Yeah.
And then do you have a cutoff on the highest mean airway pressure you would recruit to before you call this patient a non-responder?
The device. The limit of the device is our cutoff.
That's amazing.
That's awesome.
That's
What's the highest?
No, but many people get worried when we are approaching 40, 45 centimeters of water. But in some patients, that was necessary. So it's mainly the limit of the device that limits how high we can go. In prospect, I think we have limited at 35 in the study protocol. It's like what you said in the beginning. You really need to be skilled, trained, educated, and to really feel comfortable with it. And if this is not something that you're doing on a daily basis, then I can understand that you feel worried when the pressure is being upped to 40, 45 centimeters of water. But then again, the adults used in their sustained inflation, they also went up to 40.
I understand.
Oh, wow. Yeah. Now, we've talked about oxygenation. If our patient is persistently hypercapnic on the oscillator, how are we improving ventilation?
Classically, many people will dial the power knob to titrate the amplitude, because if you would increase your amplitude, you would increase your stroke volume, improve your ventilation. But since we have adopted the approach of high frequency, high lung volume, high power, we are already at 70 to 90 centimeters of water. So then if the patient is still hypercapnic, we would decrease the frequency, because with decreasing frequency, the cycle time increases and there is more time for the volume to go in there, so the stroke volume will go up. For diffuse alveolar disease, we would go as low as 8 Hertz. So we don't go below 8 Hertz, because then with corner frequency concept in mind, so 8 is the lowest Hertz that we would go. If we are at 8 Hertz and the patient is still really hypercapnic, and by hypercapnic I mean the pH is below a certain threshold, because to be quite honest, unless you have a patient with severe traumatic brain injury, I don't really care about CO2, it's about the pH. And I think many people will feel comfortable if pH is as low as 720. I would go a little bit lower, but let's say 720. Let's say that's the pH and you're at 8 Hertz and you want to improve ventilation any further, then probably the next step would be to deflate the cuff first, because you get an extra Luft phenomenon that circulates around the endotracheal tube and you get some extra CO2 elimination. If then there is no improvement, then probably you would need to increase your inspiratory time a little bit, go up to 35, 37%.
Yeah. And then thinking about those patients with obstructive lung disease that have a severe respiratory acidosis, how low would you adjust your frequency on those patients?
5.
5 would be
5 is the lowest, yeah. We see many asthmatics, they come in, they mainly present with asthma, but then at some point they progress towards more like a viral pneumonia clinical phenotype. So we do the asthma approach first. So we do the careful titration, and that gives time for the steroids to kick in. Then at some point, patient progresses towards the other clinical phenotype, and then we move to the more diffuse alveolar disease management of the high frequency, because we can see we can increase the frequency because the hypercapnic acidosis is over. That was seen because of the asthma, and it's mainly an oxygenation issue.
Yeah.
Yes, I definitely know what you mean.
Because you mentioned TBI a moment ago, I have to ask this question. Say you have a bad multi-system trauma, lung disease, brain injury. Always worried about venous drainage out of the head and managing intracranial hypertension. Would you say those patients are relatively contraindicated for high frequency, or would you use them all the same?
I would use them all the same, because I need to get oxygen in the patient, because otherwise there is no oxygen going to the brain. And there is some animal data where they measured pressures inside inside the brain, and look at how much of the pressure was actually propagated. And it isn't so that the mean air pressure of, let's say, 30 set on the oscillator is also then in the brain. It's a little bit similar to the discussion about PEEP and central venous pressure and right ventricle. A lot of the pressures that we are setting is, especially when you have a poor lung disease and there's poor compliance, is absorbed by the entire lung, the entire respiratory system, so it's not being propagated to the brain. So I think it's really safe to use in those patients as well, because the goal is to get oxygen in and CO2 out. That's what you want with traumatic brain injury as well.
Yes.
Oh, yeah. I have another disease-specific question. Hopefully it doesn't take up too much time. Zach and I did our first year of fellowship during sort of the beginning of this past 2 years of bronchiolitis surge. And I remember, of course, infants with RSV, first you try not to intubate them because you know it's a disease of secretions. And then maybe it progresses to alveolar disease, maybe it doesn't, but sometimes they end up intubated. And then once they're intubated, I remember as a first year fellow thinking, oh my goodness, I'm having so much trouble managing these patients. Should we oscillate them earlier? And was convinced that a difficulty clearing secretions on the oscillator is a reason to avoid it in infants with RSV specifically. What do you think about this?
I think the opposite. I put those with RSV who are intubated, because we keep those who are not intubated outside our ICU. That's one of our benefits. But those who are intubated, we put them relatively early on the oscillator, especially when they have broncholytic spells, because then we can reduce the sedations, can stop neuromuscular blockade. Because of the super CPAP system, they breathe spontaneously on the oscillator. They do really well.
Oh, interesting.
They do really well. And when they have these high pressures, then secretion isn't really an issue, because, it becomes an issue when you are decreasing your pressure, when you're weaning the patient.
Mm-hmm. It stents things, and yeah.
And when touching on that on the weaning, so when the patient starts to improve, because it's for the broncholytic, but it's for a lot of other patients, the patient is improving, so you're decreasing mean air pressure, more and more secretions are coming. Let's say about 15 to 20 centimeters of water mean air pressure, we go back to conventional, because our nurses think it's more feasible to do the suctioning on the conventional. So I think it's fine. So theoretically, you could wean and extubate from the oscillator, especially in small children. But in practice, in reality, we always go back to conventional as soon as we are at about 15 to 20 centimeters of water, mean air pressure.
When you have these patients at the peak of their respiratory illness and they're on the oscillator, they're on 25, 28, 30 mean airway pressure, how do you do respiratory clearance? Are you breaking the circuit for bag and suctioning?
Oh, no. It's always closed inline suctioning, like with conventional. And the nurses have to do it routinely 3 times a day, and only on indication. So if there is an issue with CO2, or if they think that the amplitude is changing, it's getting up because the resistance is increasing because of the secretions, then they do an extra suctioning. So routinely once a shift, maybe twice a shift, and then upon indication, but definitely inline closed suctioning, because you get a massive derecruitment if you break open the circuit.
That's right.
Oh, yeah.
Yeah.
And I heard something interesting there that I'd like to dig in on. In our units, because of the way that we initiate the oscillator, usually those patients for me are already on a neuromuscular blockade. If we're starting at a PEEP of 8, and it does sound like you often don't have your patients paralyzed on the oscillator.
In the beginning, we have.
Okay.
Yeah. So when you have these patients, they are approaching the criteria, they have bad lungs, we paralyze them, and we keep them paralyzed for the first 24, maybe 48 hours in the oscillator. Then we stop it. We stop it. But in the beginning, and especially during the recruitment, it's better to have a patient not showing spontaneous breathing, because they may breathe vigorously because they want to normalize their gas exchange. And then the recruitment is really, really difficult. So during the recruitment, we have them paralyzed, and we keep them paralyzed for the first 24, 48 hours.
So is it fair to say you would wait to see some evidence of lung disease start to recover before you would remove the paralytic, or not necessarily?
Yes, as soon as the patient is on the oscillator and the recruitment is done and the patient stabilizes over the next hours, we are going to start doing the so-called MAP challenges. We're going to seek the lowest mean airway pressure for that patient. Yeah, we're going to aggressively wean the oscillator again. Yeah. We do not wait for the chest radiograph to improve or whatever. So we wean and we stop the neuromuscular blockade. Then after 24 hours, and we observe the breathing pattern, and if the patient doesn't show vigorous breathing, then we keep it stopped, and we further wean the oscillator.
And something we've already mentioned for our patients with refractory hypoxemia is utilizing prone positioning. Are there any particular tips that you'd have for, I guess, how often would you prone position? How long in duration would you typically do it for your patients on an oscillator?
Well, that's a good question, because we lack very, very much PEDS data, and hopefully Prospect will answer that that answers well, because of course the one only trial we have was from Martha Curley published in JAMA many years ago, not showing benefit outcome. Traditionally, you do 16 hours prone, 8 hours supine. I have to admit, if we have a kid on the oscillator who's doing not that well and we've put them prone, we probably keep them prone for even longer, 24, 36 hours. We do rotate the head, of course, but we keep them prone a little bit longer.
Great the conversation has been, but we want to honor your time. We think you've already given us great tips on weaning the oscillator. We've already even touched on these, quote, maximum settings, that really being the non-responders to the recruitment maneuvers. If you don't have any other general thoughts on those couple points, we can jump all the way down to pitfalls and complications.
Well, pitfalls and complications, I think if you are a novice or if you're relatively new in using the oscillator, one of the biggest mistakes that one can make is when you do a recruitment that you do it too fast. You don't take enough time between the incremental pressure steps because, as said in the beginning, it takes time for the pressure to really open up the lung, and the time constant of alveoli is so much different. So that's a commonly made mistake. Another commonly made mistake is when the patient is stabilized, not doing aggressive weaning. So really keeping the patient on high mean airway pressure. And then what happens if the patient is improving? And this is real life. So what happens, for example, in the middle of the night, I get a call from the fellow or the resident, say, I have this patient on the oscillator, it's now for 3 days, seem to improve a little bit, but the patient is becoming more and more hypercapnic. And I've already decreased the frequency, but nothing happens. And then I say, okay, reduce pressure and call me back in 30 minutes. And then they call me back in 30 minutes and they say, oh, the CO2 has dropped and it's really going well. And then I explain them, the patient is improving, compliance is improving, so you get more lung volume with that same mean airway pressure because your patient has improved. And with a bigger lung aeration, you will get overdistension at some point and compression of the capillaries, resulting in hypercapnia. So that's something that people really need to understand. So that as soon as the patient improves, you really need to go down on your mean airway pressure. Another common belief, like what we discussed a little bit, is that you always have to keep them paralyzed, which is of course not the case because you, as like I said, this super CPAP system. So as soon as they start to improve, like you would do with conventional ventilation, you can stop the neuromuscular blockade and have your patient breathe spontaneous on the oscillator. And the fact that the mean airway pressure then swings a little bit, that doesn't matter because that's what the patient is doing. Just make sure, like with conventional, that the patient isn't breathing vigorously and not causing patient self-inflicted lung injury. But that principle is the same. That's a common thing. And what is really important to understand, if you have a patient on the oscillator with a sudden, unexpected increase in CO2, it's always either a pneumothorax or an endotracheal tube obstruction.
Ruling out the big things.
Always. So let's say if your patient was relatively stable and all of a sudden, out of nothing, the CO2 went from, let's say, 50 millimeters of mercury to 100 millimeters of mercury, it's either a pneumothorax or an endotracheal tube obstruction. And with that in mind, humidification is a very, very important aspect of high frequency. And so you really need to use active humidification. For example, in our unit, we use passive humidification. In all of patients ventilated conventionally, we don't use active humidification. But on high frequency, you have to do because flows are so much higher than on conventional that the air will become dry within seconds and the patient will start to have very thick synaceous secretions.
Yes. I was reflecting earlier, one of the reasons that I think locally I would just prefer conventional so much is because I just enjoy. I find it so useful to see the end-tidal CO2 on the monitor all the time, and you lose that with high frequency. And I was wondering, what are your bedside tools that you use to monitor CO2? Do you use transcutaneous monitors? Do you get frequent blood gases? What's your strategy?
We use transcutaneous CO2 monitoring, even in older children, because we've seen, if you do too many blood gases, we want to avoid that, like for any other reason. We don't want to draw that too much blood. And the CO2, it works relatively well, even in, let's say, the 1 or 2 year old, because the majority of the population is below 2 or 3 year old. So CO2 works, transcutaneous CO2 monitoring works really well in those patients. And it's not the individual number, but it's a trend. So let's say we do 4 times a day in the beginning a blood gas, but we can see the trend on the transcutaneous CO2 monitoring. So that's something that I would really recommend to have.
Oh, thank you. That's good to know.
Well, Dr. Martin Kneyber, this has been a fantastic conversation. I've learned so much. I feel like glass ceilings that I had on the oscillator have been broken down, and I have new opportunities with this, I wouldn't say old, but antique machine that's in the corner of our PICU.
Yeah.
I wanted to give you one last open question. Feel free to share any additional resources. Feel free to mention more about your prospect study. Anything else that you'd like to plug for our audience before we wrap things up?
Well, thank you. First of all, it's been a big honor of being here today on this podcast, and I'm happy to chat further if you would like to. To all the listeners, please go to the Prospect website. It's not just to get you on the study, but the protocol on Prospect is open. It's out there. And the approach to how I use the oscillator, it's incorporated in the Prospect trial. So it's really detailed and it's stepwise, and it shows you about the recruitment maneuver and about the daily map challenge to aggressively wean again your patient from the oscillator. So please feel free to use that protocol, because that's what we've also learned from the sites who are in Prospect when a patient is potentially eligible and they are trying to improve the patient to really patient eligible, and they are already using components. And if a patient, for example, if parents refuse, they still use the Prospect protocol. People start to feel comfortable with this high frequency approach. It's completely different from what we have been taught and what we've been using for the past 50 years. But well, go to the Prospect website and make use of that protocol. And if you have any question whatsoever, please don't hesitate to shoot me an email. I'm happy to answer any question about this, about anything, if you want to know.
Well, thank you so much. That's an incredible bedside tool that Zach and I will certainly be using, and we hope our listeners follow suit.
Perfect.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.
Zach, during our conversation, I heard you mention that you didn't enjoy looking at the end tidal CO2 tracing, and I have to tell you something. I really do enjoy looking at the end tidal CO2 tracing. I think it gives you a lot of information about the patient, and I do enjoy it.
I think I enjoy it too, but I wasn't comfortable admitting it.
Yeah, no, of course.
That's amazing.